Hemophilia is a rare disorder affecting about 20,000 individuals in the United States. Due to insufficient blood clotting proteins or blood clotting factors, the blood does not clot normally. The complications of improper care can be severe. Our expert panel today will provide a thorough understanding and best practices for the treatment of hemophilia. I am Dr. Luigi Brunetti, an associate professor in the Department of Pharmacy Practice and Administration at the Ernest Mario School of Pharmacy, Rutgers University in Piscataway, New Jersey. Joining me today are Dr. Robert Sidonio Jr., the Associate Director and Director of Clinical Operations and Clinical Research in the Hemostasis and Thrombosis Program at Children's Healthcare of Atlanta in Atlanta, Georgia, and Giles Slocum, an Emergency Medicine Clinical Pharmacist Specialist and Factor Stewardship Pharmacist at Rush University Medical Center in Chicago, Illinois. Thank you so much for joining us. Let's begin. Before we get into some of the clinical pearls, I think it's important for the audience to understand a general overview of hemophilia. So perhaps, Dr. Sidonio, I'll address this to you. Can you briefly discuss the genetic alterations associated with hemophilia A?
Yeah, so hemophilia A, just like hemophilia B, is both X-linked recessive disorders. And so thus it's primarily affected by males, and there are some situations in which females may lionize and express the disorder, or if they have Turner syndrome, but primarily it affects males. It affects about 1 in 5,000 males in the United States. Doesn't have any racial predilection. And it's much more common in hemophilia B, which is about 1 in 25,000 males. And so, it's really important when people are getting their history, they understand the genetic inheritance pattern, because oftentimes mothers will be carriers. You don't know who's going to have the spontaneous mutation. So about a third of the cases, there may be no family history at all, because it may sort of skip generations just because it has only unaffected males in it.
Mm-hmm. And in terms of diagnosis, I mean, when is a diagnosis of hemophilia suspected? The
way hemophilia is diagnosed, ideally, it would be nice if all of the women were diagnosed as carriers. We would get notification, we'd do pre-genetic counseling, and we'd be prepared for the potential of a male child having hemophilia. And that's important because it's important for us to know for discussions about whether the delivery needs to be a C-section in preparation for diagnosis. Ideally, you can actually make the diagnosis from the cord, so you actually don't have to stick the child, which is always ideal. You don't want to stick a child that may have a bleeding disorder. Even a heel stick could lead to prolonged bleeding. And certainly you want to make the diagnosis before a decision about a circumcision. That's often, unfortunately, the way a diagnosis is made. And sometimes patients are diagnosed a little bit later if there's no family history. And it's really important for people to understand that there are different severities. And so in severe, they have less than 1%. In moderate, they have 1 to 5%. And in mild patients, they have anywhere between 6 and 50%. And so even recently at our center, we diagnosed a 10-year-old with mild hemophilia. He had bleeding symptoms, but they were mostly related to trauma. And so it's important for people to know their different severities, get a good family history. The sort of laboratory way we diagnose this is some people can use a screening PTT assay, which isn't good enough to screen for mild disorders in general. And so it's always good to send factor VIII. And if you don't know, it's better to send both factor VIII and factor IX, because some families don't know what type of hemophilia they have.
Okay. And in terms of complications, and Dr. Slocum, I guess this is something I can address to you. Often these patients will present to the emergency department. What are some of the complications that you see in patients who have hemophilia A?
Yeah, so kind of like what was just previously discussed, there's that spectrum of severity, right? So depending on where they are along this continuum of the severity, we typically see people coming in with large joint bleeds, muscle bleeds. Those are probably the 2 hallmarks that we see in our own emergency department. So those are kind of the areas that they usually present to.
Yeah, and I guess in terms of risk factors, there are many, right? I guess it depends on how active an individual may be with hemophilia A, and then there could be some drug risk factors as well. So that's something maybe I could address both of you. How do you handle some individuals perhaps with hemophilia A that are older that may use over-the-counter products such as NSAIDs? I mean, What
Yeah.
are your thoughts on that?
Yeah, so in the care of pediatric patients, we pretty much avoid any use of NSAIDs. What's interesting is when we see our adult colleagues, it's not unusual to see them on ibuprofen, for example. And there's very limited data on the utilization of that. And in certain circumstances, it's probably relatively safe. But chronic use obviously could lead to side effects like GI bleeding and could make their bleeding symptoms worse, particularly in adults who may or may not be on prophylactic factor therapy, and I know we're going to talk about that in a little bit. And so it's a tough discussion, particularly in this day and age, when you're talking about pain management and we're trying to limit our use of opiates. And we've had some of the other products have been removed from the market, so it can be challenging. But getting a good history on the utilization of those medications and trying to replace them, particularly if they have headaches, with medicines that are more safe.
Sure. And in terms, oh, go ahead.
Yeah, I'd just like to pick up on that as well. So a lot of our patients in our patient population, in our electronic health record, sometimes you'll see like aspirin and NSAIDs as like allergies. And I think it's something important to note that if they're not actively bleeding or depending on the severity that for headaches, and as long as it's not for chronic use, it's something that just to piggyback and say, I think it is probably appropriate and can be tolerated.
Yeah, and this may be something we circle back with when we talk about treatment goals, because some patients, in fact, need aspirin, right, or need to be on an antiplatelet agent, and we can talk about how we handle those situations.